Okay, here we have our patient who had a metastatic melanoma of the trachea, and we have done a tumor debulking before. Right now, we are going to check and possibly plan a intravenous metallic airway stenting. Now you can see that we are going inside. We are able to see the vocal cord, and most of the tumor has been effectively debulked. Now you can see that there are some retained secretions in the airway. And this small portion of the residual tumor is left. So since it's sort of a mixed sort of tumorous growth, we may have to do a stenting to prevent the tumor ingrowth into the trachea again. I think we should plan on how far it is from the vocal cord. Okay. So see the measurement, right? Yes. Right now we are seeing how far it is from the vocal cord. Okay. 27 going. Then here it goes. So we have like 30. We have 3 centimeters margin. So still we have a lot of margin. Not be a problem. Tracheal stent, and as you can see from here, this is the stent that we are going to insert. It is a 18 into 6 mm stent. Okay. So each stent has a different sort of a deployer. So here we have this Java metallic stent, and as you can see from here, there is a deployer here, and as I push, there are 3 markings. The moment you cross the red marking, you cannot withdraw the stent inwards. So if you push the stent, it starts opening up. As you can see from here, it's a self-expanding one, and if I want to take it back, I can take it back till I go till the point of the red, and once I cross the red, I will not be able to retrace back the stent. Okay, silicone spray. So right now we are going to do this stenting. We are going to do this stenting under rigid bronchoscopy. Okay, so and saline flush with saline. Okay, done. Now we are going to position the patient for rigid bronchoscopy following the inspection bronchoscopy. Position the patient for rigid. So as you can see from here, we need to be extremely cautious in holding the neck of the patient, and we are keeping a shoulder roll below so that we have a sniffing dog position. And now you can see that the headrest is kept below so that there is no undue extension of the neck of the patient. Now you can see that the patient is being positioned by the anesthetist. This is very important before you do a rigid bronchoscopy. And now once the patient is positioned and things are in place, now we will do the rigid bronchoscopic intubation. Okay, now you can see the anesthetist removing the laryngeal mask airway, and now we will first do the oral suctioning to make sure that we don't have secretions before we go in for the rigid bronchoscopic intubation. Now you can see that I am passing the rigid scope, and you can see initially I identify the uvula, and once it is done, I bend the scope onto my thumb, which acts like a fulcrum, and I am able to see the epiglottis. Now I'm going below the epiglottis. I'm able to see the vocal cord. I rotate my scope, and now I am inside the airway. Now we are securing the rigid in place. Prism, prism, prism. And now you can see that we will be packing the oral cavity. Okay. Again, I do a check bronchoscopy. Hold the rigid in place. To see if the rigid is in place. Yes, the rigid is in place. And now we will be going in for airway stenting. Okay. It is a 14 size rigid barrel, so that this allows us the space to pass the scope. Okay. Hold the rigid in place. Okay. Wait. Where man you keep it na yaar. Arey you need not change it tonight. Now you push. Continue. So slightly. See there, see there. ठीक है? Lower bottom. No, you keep the upper bottom. Continue. Bas. ठीक है? Till here we want the upper margin of the stent. We have to be neck to neck. Jugular is there, be careful. Okay. Continue. Okay, na? No. Okay, wait. Now 6 centimeters. 1, 2, 3, 4, 5, 6. Continuous. Now we mark the lower end. Upper margin. Both are upper margin, no? Yes, both are upper margin. So we have to start deploying here. Wait. 40, na exact. Okay. We have to start deploying here, right? Okay. Okay, continue. Wait. Now, again we'll recheck. From here, this is the origin of tumor. Continuous. Yes, perfect. So, 1, 2, 3, 4, 5, 6. Continue. No, 40. Continue. ठीक है ना? Okay, 40. Have to come to 34. 1, 38, 37, 36, 35, 34.
34 above.
Huh?
34 is not man.
Continue. That means wrong, na? Wait. 39, 38, 37, 36, 35, 34. That 34 is inside. That means we are keeping it at 34.5. 34.5. That means we have to go till 40.5. You know? 1, 2, 3, 4, 5, 6. Now you should continue. So, no. See, lower is very important because you start from lower. It should not go down, it should not go up.
So maximum
Okay.
lower border.
So we have to choose somewhere mid, or if we go upper, how many distance we have between vocal cord and the tumor?
Total 3, we have
We have exactly at 1. Even 1 need to go up. So we have to put a little above. Hello? Chalo, wait. You go in now. Where is the tumor?
the thing is we didn't process before this like again we don't have this markings.
I think
Same as your adults.
Not required, no? We are going by, that's why we marked outside. Suction. Okay, continuous. Continue. Okay. And here. Okay. Continue. We want it midway now. Is it proper?
Just you want to pull up,
little
now okay?
bit.
Come to stage on. That's sir, in between.
In between.
Start.
Ma, it's going down or correct?
Correct.
Hey, continuous here.
Correct or going down?
Correct. Only straight step coming down.
Are you sure?
Yes, sir. Straight came down, sir.
Now?
Now okay. Scale is down, coming down.
No?
Now also came down, sir. Little up.
No?
Little up. Yes, sir.
Okay?
Now okay.
Sure?
Yes, sir.
Correct?
Yes, sir.
You see here. Correct?
Yes, sir. Little up, sir.
Is it opening here?
Yes, sir.
Hold the screw.
Perfect.
Perfect, correct.
Exact.
Perfect. Now wait, don't do anything. Sir, LMA. Perfectly done. So, wait, don't put the weight.
Sir, we'll unpack. కింద పెట్టేసా
Thread remove that.
ఓరల్ సక్షన్
Done. Now we have successfully deployed the stent under rigid bronchoscopy. Now you can see that I am passing my pediatric scope to have a visualization of the post-deployed stent. Okay, now you can see I am going through the vocal cord, and we have enough margin away from the vocal cord so that there is no possibility of granulation tissue obscuring the vocal cord. And now you can see that the stent is positioned in place, fully covering the area of the tumor, and even the distal margins are covered adequately, so there is a less chance of tumor ingrowing into the airway. And now we are done with the procedure and we are coming back. Okay, this is the thread which can be used for pulling up the stent, but in this case we are not pulling it up because we want to give enough space away from the vocal cord to prevent any sort of a subglottic granulation tissue. And now we are moving out. Lignocaine.